Welcome to the Mountain West AETC Project Echo. I'm Kent Unruh, and I'd like to turn it over to our medical director, Dr. Brian Wood, for the talk today.
We have a packed session, so I'm going to dive in. You get me for another segment of the CROI review, and then next week I will hand the baton over to Ann Collier. I'm going to talk today about novel ART strategies, mainly some new data on dual therapy and monotherapy. And then next week, Ann will talk about new ARV drugs. There was a lot about new ARV agents at CROI, so she will cover that next week. But this week, talking about monotherapy and dual therapy. And here, I'm actually just going to start with the punchlines and then show you the data. So first, a dual combo tablet of dolutegravir-rilpivirine has been submitted for approval to the FDA, and now we're going to look at some data for dual therapy. So I'm marking this as coming soon. We have another pilot study of dolutegravir plus Lamivudine, and so I'm calling that promising. And then we have a study of dolutegravir monotherapy, and my punchline here for you is don't do it. And we'll talk about why. As background, I think it's interesting the way the pendulum has swung from the early days of the HIV epidemic and studies of mono and dual, mostly NRTI therapy that really wasn't effective in the long run, and then data for three-drug therapy obviously working and being best, and years of three-drug therapy being our staple and our go-to. So now why all this new interest in dual and monotherapy? I think there's a few reasons. So obviously it does have the potential to reduce pill burden and reduce side effects. And then my impression is I think a lot of the interest is also to reduce cost. A lot of the data is coming out of Europe, as we've talked about, and I think there is a lot of motivation to cut down on cost. And really the reason that this can be studied now is because we have potent agents that are well tolerated and that have high barrier to resistance, with the main one being dolutegravir. And you'll see that that is part of all three of the studies I'm going to show you today. And then boosted darunavir is the other one I think that holds a lot of promise, but I'm not going to talk a lot about that here. So first, SWORD is an industry-sponsored study of switching to dolutegravir plus rilpivirine for two-drug maintenance therapy. This was a multinational study but presented by an investigator from Spain, and I'll show you the background, inclusion criteria, and sort of strategy and design of the study, then the participant characteristics and results. So these were two studies, and I'm going to show you this pooled characteristics and pooled results. So I'm going to treat this as sort of one large study. So these are randomized, multinational, open label, industry-sponsored studies. So that always just raises my eyebrow a little bit. They were open label, they were sponsored by the drug company who's making that combo pill. But with that caveat in mind, I think we do get interesting data here. So they were randomized non-inferiority studies. And here's the inclusion criteria, which I think is always key for switch studies. So all of the individuals in these two trials were on stable three-drug ART with two NRTIs plus an integrase inhibitor and an RTI or boosted PI for at least 6 months. That regimen they were on was their first or second regimen with no prior change due to virologic failure. And their HIV RNA had to be below 50 copies for at least 12 months. And they could not have any evidence of hepatitis B infection because obviously the two-drug regimen would not adequately treat hepatitis B. So they enrolled individuals with those characteristics and then randomize them in one-to-one fashion to either two-drug maintenance therapy with dolutegravir plus rilpivirine, or they continued their current three-drug ART, and that went on for 48 weeks. And then this is the primary endpoint that I'm going to show you today and that was presented at CROI. So this primary endpoint is after this 48 weeks, the proportion with HIV RNA less than 50 copies between these two arms. At 48 weeks, actually, sorry, at 52 weeks here, they transitioned everyone to the two-drug arm. I think actually this is a typo. This should be the total, just over 1,000 patients. And then this group is going to continue until 148 weeks. But this is what I'm going to show you today, the 48-week primary endpoint. These are the characteristics, which I think are pretty standard of most switch studies. Mean age of 43, very high CD4 count on ART for a very long time. Most switch studies do intentionally select for patients who are going to do well with the switch. Interestingly, they got out about 20% women in the study, and they highlighted that in the presentation as being really good. I think that just shows how much struggle there still is to enroll women in ARV-related clinical trials, but it is better than, for example, a lot of the Gilead trials that only had 10%, but I think that is still a limitation and issue, and you can see here the baseline anchor drugs that were used, with the majority being on an NNRTI and a lot being on TDF as part of their backbone. So my impression is a lot of people here were switching from a triplet or something similar, and then you can see here about 26% switching from baseline PI, 20% from an integrase inhibitor-based regimen. And here's the outcome. So you can see here, this is the proportion with HIV RNA less than 50 copies at 48 weeks, and you can see absolutely equivalent between the two arms, so clearly non-inferior. So these, I will say, carefully selected individuals with well-controlled HIV and really no past virologic failures did very, very well switching to this two-drug maintenance arm. The extra 5% here, the 5% who did not have HIV RNA less than 50 copies, mostly were counted as failures because they didn't have data. There were a couple lost to follow-up, there were 2 deaths that were unrelated to the ARVs, but mostly these people were counted as failures because it was intention to treat and they just didn't have data. There were 2 virologic failures in each arm. There was only 1 instance of resistance, which was this NNRTI resistance mutation in the 2-drug dolutegravir plus rilpivirine arm. There were no instances of integrase resistance, and they went into more detail about this particular patient who had switched from A-tripla with a very high baseline viral load prior to starting A-tripla, and then at the time this mutation was detected, admitted to non-adherence, had a viral load that was very, very high, I think near 1 million if I remember right, and they're going back and looking at stored samples to see if this was actually present at baseline. And intriguingly, this patient actually suppressed with just restarting dolutegravir rilpivirine. They basically decided to restart before they knew about the mutation, and then the patient suppressed, which I guess ends up being more or less dolutegravir monotherapy, which I'm about to tell you don't do. So I can't fully explain what happened with this patient, but I do think it's reassuring that there was no integrase resistance and most people did very, very well, though I want to give the caveat that these are very carefully selected individuals. In terms of adverse events, there were more grade 1 to 2 AEs or adverse events in those who switched to the 2-drug arm. I don't think that says anything about dolutegravir and rilpivirine. I think these are individuals who were stable on a regimen for a long time and switched to 2 new drugs. So I don't think that's really surprising. There was, with the switch as compared to continuing 3-drug ART, there was really no difference in lipids over time. But importantly, the investigators haven't stratified by which regimen people were switching to. For example, if someone was switching from a boosted PI or switching from efavirenz, I would assume a better benefit than switching from raltegravir or rilpivirine. So I think we need more data there. There was significant improvement in bone biomarkers, so not surprisingly, a lot of people started on TDF, then going to the 2-drug therapy. Markers of bone turnover and bone mineral density did get better, and they are doing a bone sub-study. So my conclusion, my take-home from this is that in this industry-sponsored study, which enrolled very select individuals with well-controlled HIV for a very long time with no past virologic failure and no significant resistance, dolutegravir plus rilpivirine was non-inferior as 2-drug maintenance therapy. And so I think for certain individuals, this may be an option to consider in the future. And interestingly, the drug company has submitted for regulatory FDA filing of a dolutegravir rilpivirine co-formulated single tablet. These, of course, are both very low-dose small tablets alone, so this could be a very small single tablet maintenance regimen, though I will also give the caveat I have not switched anybody to this yet personally. Let's go then to another 2-drug maintenance option, which is, this study is called Lamidol, which is kind of a celebrity couple mashup name of Lamivudine and dolutegravir. And this is a little different. This was more of a pilot study. So this is a single-arm, non-comparative trial. So what they did here is they simply enrolled individuals, switched them to dolutegravir plus 2 NRTIs, made sure they were suppressed at 8 weeks, made sure HIV RNA was less than 50 at 8 weeks, and then switched all who had a suppressed viral load to 2-drug dolutegravir plus 3 TC. So they switched everybody to sort of 3-drug induction, made sure they tolerated it, make sure HIV RNA was suppressed, then went to 2-drug maintenance therapy. So there really were sort of there was a switch here and then a simplification. The inclusion criteria here included a nadir CD4 count that was above 200, an HAV RNA that was less than 50 for at least 2 years, standard first-line 3-drug ART, just like in the last study, with a maximum of 2 modifications of ART for simplification or intolerance only, not for virologic failure or resistance, and additionally, no modification within the past 6 months. So again, these are very carefully selected individuals. This is not the person who has struggled with adherence, had a lot of virologic failures, or has resistance. They did have to have a wild-type HIV on a genotype, but most did not have baseline integrase resistance genotypes, is one thing the investigators pointed out. And again, they could not have Hep B co-infection. And so, again, all of the people in this study switched to dolutegravir plus 2 NRTIs, took that for 8 weeks, made sure their HAV RNA was less than 50. There were 6 people in whom that was not the case who withdrew before this point. 3 had an HAV RNA above 50, and 3 just didn't tolerate this switch. So then we get 104 people entering the 2-drug maintenance, single-arm 2-drug maintenance, and what we're looking at now is the data at 48 weeks. So actually it ends up being 40 weeks of 2-drug therapy is what we're going to look at. The baseline characteristics, again, are not surprising. Median age of 45, mostly male, median 6.3 years of ARV and 4 years on ART, with nadir CD4 counts that were not low and current CD4 counts that were quite high. And you can see here the regimen that individuals were on before enrolling in the study, and the baseline integrase inhibitor was pretty evenly split. About a third were on raltegravir, a third elbitergovir, and a third dolutegravir. And here is the result. So this is a single-arm study, so we're just looking at the efficacy of all those people who took 2-drug dolutegravir plus 3TC for 40 weeks. And you can see here 97% remain suppressed. So very effective, no comparison here. This is a pilot study, so I'm calling this promising. So at that endpoint, it was 101 out of 104 individuals who maintained virologic suppression. Those 3 individuals who didn't, 2 basically had low-level viremia, RNAs below 200 copies, and the other one was lost to follow-up. So no one who failed this really failed with a high viral load or with resistance. So I'm calling this pilot study sort of promising, and we need more data on dolutegravir plus 3TC. But I think this adds to PADDLE, which was the pilot study of 3TC plus dolutegravir in 20 treatment-naive individuals, looked really good. And because of these 2 studies, there are additional trials enrolling. So ACTG 5353 is a trial enrolling treatment-naive people and studying dolutegravir plus 3TC as initial therapy, as is Gemini. Gemini is doing the same thing. It is sort of the industry-sponsored version. And then I think we will see more data on dolutegravir plus 3TC maintenance therapy in the future. So promising pilot studies, but we need more data. Let's turn then to DoluMono, which is dolutegravir for maintenance monotherapy, another trial from Europe. And here, I think the design was fairly interesting. So this is a randomized trial. It's open label again, multi-center, assessing the non-inferiority of switching to dolutegravir monotherapy versus continuing 3-drug therapy. Similar inclusion criteria on 3-drug ART, suppressed for at least 6 months, an HAV RNA peak or zenith below 100,000, and CD4 count nadir that was not below 200, no baseline resistance and no history of virologic failures, and no Hep B. Individuals randomized 1-to-1 for the first 24 weeks to either dolutegravir or continued 3-drug ART. And what we had seen before was this 24-week data was non-inferior, and it looked really promising. Now what I'm going to show you is the 48-week data here after everyone switched to dolutegravir monotherapy, and it does not look so good. So at 24 weeks, when they compared dolutegravir to continued 3-drug ART, they reported the outcomes as being non-inferior. Then everyone switched to dolutegravir monotherapy, and now we're going to look at 48-week data. And interestingly, what the investigators did, because they didn't really have a control group here, is they added in 152 3-drug controls, basically from other trials. Slightly suspect and kind of fishy trial designs, and if you've read, there was a recent commentary by Joel Gallant on some of the dolutegravir monotherapy studies, bringing up the fishy ethics of a lot of the dolutegravir monotherapy studies. So I'd encourage you to read that paper. I think it's a really good paper pointing out issues with a lot of dolutegravir monotherapy data. I'm not going to show you the baseline characteristics for time because I think it's similar to the other studies. I'm just going to show you the outcome, which importantly shows that dolutegravir monotherapy maintenance is inferior to continued 3-drug ART. You can see here a significant difference in the proportion with HIV RNA less than 50 at 48 weeks. The study was actually stopped early, and in the dolutegravir monotherapy arm, there were 9 virologic failures. 3 did have integrase resistance, including some significant integrase resistance mutations. And whereas in the dolutegravir 3TC, in the 2-drug arms, most people who failed had low-level viremia, these individuals actually had viral loads that were well above 200 and more consistent with failure. Most were in the 1,000 to 5,000 range, and there was one who was up at 70,000 despite reported excellent adherence. Importantly, all the individuals who failed this did resuppress with reinitiation of full 3-drug ART, but the conclusion of the investigators is the genetic barrier of resistance of dolutegravir is insufficient to allow for maintenance monotherapy. Future studies should evaluate dolutegravir plus 3TC and not dolutegravir monotherapy. So I think a lot of consensus now that dolutegravir monotherapy is probably not the best idea and that 2-drug dual therapy arms are better and are what should go forward in study. And there's a lot of suspicion about the ethics and design of some of the dolutegravir monotherapy trials. So just in summary, based on this data, the consensus is to avoid dolutegravir monotherapy. Dolutegravir plus a second agent, dolutegravir plus rilpivirine is probably the one with the strongest data, or dolutegravir plus 3TC looks promising, we'll get more data, are worth considering, I say here, for select individuals. There is an ongoing trial of dolutegravir plus boosted darunavir dual therapy. We just need to see data from that. And so my question I'll leave you with before we turn to questions and comments, I'll just leave you with this to ponder. Would you ever consider these 2-drug maintenance options now with all of our well-tolerated agents and with TAF and with all the options that we have? Would you consider 2-drug maintenance therapy for your patients, and if so, for which ones?